Campion Lecture is named after Sir Harry Campion, who was first director of the Central Statistics Office. That's basically the ONS now, so sort of Ian's role, if you were here yesterday. He was there from 1941 to 1967. That's Harry, not Ian. He was also inaugural director of the United Nations Statistics Office and was also a past president of the RSS. He has also left a very generous legacy to the RSS to support future statisticians. I'm absolutely delighted today to invite Christina Pagel to give a Campion Lecture. She is Professor of Operations Research and is ex-director at the University College London. She is a member of Independent Sage. You might see her a few times on the telly. She's taken part in many live streamed briefings, plus many interviews in the print and in media. And she certainly entered the lion's den of Twitter, which is now X. So it's going to be very interesting to hear her thoughts. She's won a number of awards. In fact, she's won an RSS Awards at the 2023 Statistics Excellence in Journalism Awards. She won the Best Statistical Commentary by a non-journalist, entitled Physics, Do Girls Avoid It Because It's Too Hard? She's also been awarded Companion of OR with the Operational Research Society and received awards in communication from the BMJ and Health Watch UK. So it shouldn't be a surprise to find that her talk today, or lecture today, is around communication, which is a tour through evidence-based public health policy, communication of data, and the roles of the scientist. We'll have a Q&A at the end, and we're told that the app is working, so if you want to ask any questions using the app, I will try and filter those through, and we'll see what comes out. So over to you, Christina.
Well, thank you for having me. So the structure of today's talk is I'm going to start by just going through the basic coronavirus pathway and going through a couple of kind of a vicious circle for transmission and thinking about, given that where there was really brilliant science during the pandemic, where it wasn't quite enough, where you might have potential interventions, and then how that's kind of fed into how I see myself having interacted with the media and how I have seen my role as a scientist in the media, which is something, incidentally, that was never planned for and was very much an accident. So just to kind of remind you on this, and the reason I want to go through it is because actually it really matters for how you look at data and how you use data in the pandemic. So you start off being exposed, and then you may or may not get infected. And then a day or two later, you might become infectious. And then you either never develop symptoms and you have an asymptomatic infection, or you do develop symptoms and you start feeling ill. That's typically days 2 to 7. And then you either recover at home, most people do if you have symptoms, and very few people end up in hospital. And then you end up with the three main outcomes, right? You can die, you can end up with long COVID, or you can recover from your acute infection. And sadly, with COVID, after a few months, you go back into the susceptible pool. And exactly how long it is depends on the individual and vaccination and all the rest of it. So if we actually want to think about the main impacts of coronavirus infection, if you're sick or you're infectious, if you're asymptomatic, your main impact is that if you're not isolating, you can infect other people. And if you are isolating, you're not working or in education unless you can work from home. And if you're non-hospitalized, you're sick and off work. If you are hospitalized, that adds to a burden of hospital care, and potentially you can also infect healthcare staff and other patients. Death is obviously the ultimate bad outcome, but long COVID is now increasingly recognized as actually a really significant outcome. It adds both burden to the health system longer term, but it also takes people out of the workforce, and we are already in the labour force shortage. If you recover, that's great, but there is statistically a higher chance of long-term adverse outcomes and death, at least for the first year after infection. So that's kind of the timeline. So let's look at a vicious circle. There's more than one, but I'm going to look at the one on transmission. And I'm going to start just with high numbers of infections. And often it takes off first in under-vaccinated groups who mix. That's typically children in schools or young adults in the workplace or university. As more and more people have become infected, vaccination is playing less of a role, but even then, it's still in populations who mix a lot, and that is disproportionately children and young adults in schools. This is from the ONS infection survey, which is based on random testing, and it's really the gold standard for looking at population prevalence. And this is prevalence of coronavirus in England over time from its beginning in August 2020 all the way up until the end of March this year when it stopped. And you can see that most adults were double vaccinated by the autumn of 2021. Then Omicron came, and in no way did it have a really big impact on prevalence, unfortunately. We've continued to have really high prevalence. It went down quite a bit this summer. We don't know exactly to where, but it is currently going up again. ONS also released estimates of incidence, so new infections, and their best estimates are that there have been enough new infections to infect everybody between 1.3 and 2 times, right? So some people have none, some people will have 3, 4, 5 infections, but by age, the highest number of new infections has been in school-age children. So that has consequences, right? If you have a high number of infections, you end up with a high number of people off sick. Just one stat is that in 2021, for instance, COVID-19 accounted for nearly 1 in 4 of all work absences for sickness. If you have an understaffed workforce, there's also then more pressure to work if you're sick, or especially if you're asymptomatic, but testing positive. And part of the issue that we have in the UK is that we have very low levels of statutory sick pay. And so actually for many people who, whether they're self-employed or on a 0 hours contract or an insecure employment, they literally cannot afford to stay home from work. And that means that you have more people who are infectious potentially out and about, and that leads to more exposure and it leads to more infection. And then over time, that also leads to more mutations and more variants. So this is prevalence of coronavirus, exactly the same graph as before, but I've overlaid the periods of the different variants. And you can see since Omicron came in December 2021, we've had 5 main variant periods. We've had XBB pretty much all year. But just over the last month, there's a new variant on the block called BA 2.86, or some people call it Parola. And this is interesting to people because it has a lot of new mutations. It's as different from the current Omicron variants as Omicron was from Delta. So that's why it's being watched really closely. And it is definitely growing, but we still don't know very much about it. So it's still really early days. And then you go back into another wave. So that's kind of the vicious circle for transmission. And if infections didn't matter, we wouldn't care, right? It doesn't matter, so what? But lots of infections, they do have consequences. The consequences may not be as severe now as they were 2-3 years ago, but there's still consequences. One is on education, particularly in 2022. In the first wave, in January 2022 of Omicron, there were days when 5% of all children, all teachers were off sick with COVID. Last summer, there was a warning from the Department of Education suggesting that more than 1/3 of secondary schools are reporting workforce challenges due to long COVID, and the teaching profession is one of the professions that's most hit by long COVID. And speaking of long COVID, that is an issue. This is from the ONS infection survey, long COVID, where they asked people who've tested positive, are you still experiencing symptoms of COVID? So it is self-reported. This is symptoms for more than 12 weeks. And this is as of March 2023, which is the last data point we have. And it was almost 2 million people, 3% of the population. Now, 20% of them said it didn't affect them at all, fine. But about 2% of the population said actually their activity was limited to some extent, at least. And that has almost doubled since August 2021, right? So vaccination definitely is protective against long COVID, but it is not completely protective. The estimate says it reduces it by about 50%, and we've had a lot of infections. There's obviously then the impact on NHS and death. So this is weekly deaths in England and Wales by death certification. So this is COVID on the death certificate. Someone has judged it to be on that causal pathway to death. It's not deaths with, it's death from, or at least partly from. And yes, in 2020 and 2021, we had almost 150,000 people died from COVID. But it hasn't gone away. It's got a lot better, but it hasn't gone away. So in 2022, we had 33,000. So far this year, we've had 12,500 COVID deaths. And that compares to an average pre-pandemic annual deaths from flu and pneumonia of about 27,000, right? So, and we're on track for that kind of number, maybe slightly less from COVID-19 this year. So we've added a new disease to our population that was already straining in the NHS every winter, and we've added it, and it comes with a similar death burden to flu. So that is quite a significant addition. And the other thing with COVID is that actually it's not yet seasonal. Maybe one day it will be, but at the moment it isn't. So there's waves throughout the year, and sometimes they coincide. So last December we had, not a massive COVID wave, but a significant COVID wave. We had quite a big flu wave, and we actually also had an RSV, another respiratory virus wave, and it caused effectively a situation where the emergency services in the NHS almost collapsed for several weeks. And the head of the ambulance services has effectively broken our social contract. We don't know that you'll get an ambulance. We don't know how long you're going to wait in A&E. And here's just an example of that. This is the % of A&E attendances where people had to wait more than 12 hours from the decision to admit to hospital admission in England. And you can see that pre-pandemic it was effectively zero. It was starting to get worse in winter. But last December it got to over 10% of people waiting more than 12 hours. And we know that that is associated with higher mortality, and the actuary group estimated that 500 extra people were dying a week in December because of delays accessing emergency care. And if we measure it from the time of A&E arrival, it's even worse, and over 50% of people waited more than 12 hours last December, and it's still almost a third of people waiting, even now in the middle of summer. There's economic disruption. So this is from ONS. ONS is an incredible resource, by the way, showing UK sickness absence rates in adults. And 2022, which was the first full year of Omicron, was the highest sickness rate absence since 2004. Now, of course, not all of that is COVID, but it's certainly a significant contributor. And in terms of a long COVID workforce disruption, or rather long-term workforce disruption, this is again ONS looking at the cumulative change in economic activity because of long-term sickness compared to 2019. So it starts off being zero, and then every month we've added to it with more people saying, I can't work because I have long-term illness. And it's now at about 400,000 people between 16 and 64. So that's certainly, again, it's not just long COVID, it's all kinds of other things, including things like the NHS waiting list being at record levels and people getting sicker waiting for treatment. But if you compare it to the 360,000 people reporting long COVID that severely limited their activities, you can see that there probably is not a direct overlap, but there will be significant overlap between those two groups. So let's think about some of the brilliant science. Vaccines is obviously got to be up there, and there's still hundreds of vaccine trials going on around the world. And to date, over 13 billion COVID vaccines have been given in 184 countries to over 5.5 billion people. I mean, that is an incredible success story for science. And there's a vast body of evidence now that they're safe and they're effective. New treatments were identified and developed, and here the UK played a really, really important role with setting up things like the recovery trial, which enabled really rapid evaluation of new treatments. And it was really important, not just for discovering cheap treatments that already existed, like a cheap steroid that improved survival in ICU, but also establishing things that didn't work, like hydroxychloroquine or ivermectin. So I think that has also been a success story. I actually think mathematical modeling had a good pandemic, right? A bad press, but I think a good pandemic. And really, for trying to make policy decisions very quickly, there's no real other way you can try and decide between different options without doing the kind of scenario analysis that modeling enables you to do. The UK surveillance system is really world-class. I'm just going to have 2 slides on it. One is that we worked out very quickly who was at risk and understood that. We have really good data on things like demographics, ethnicity, deprivation, employment, and so on. And so we realized not just about age, but in terms of key workers, areas, ethnicity, and so on, And that includes things like the Imperial React studies and the existing centralized audits we have in ICUs. In terms of surveillance, you had the ONS infection survey, which I think has been a real world leader in national prevalence estimates. You also have really good reports from the UK Health Security Agency, their weekly flu and COVID surveillance report. But also, they really are world leaders in coming up with risk assessments of new variants, fast, accurate, public data. The test and trace data was public and published very quickly, and so on. So I think that's been really, really good. And then we've also had the COVID Genomics Consortium. We are one of the world leaders in tracking and spotting and understanding new variants. So I think we can be justifiably proud of the surveillance system that we built up here. There was also really good science in terms of understanding transmission and how to prevent transmission, right? This is a paper that came out in September 2020. By then we knew, scientists knew, that it was an airborne disease. And this figure kind of highlights the three main ways you can remove infectious aerosols from infecting other people. One is you allow air exchange, right? You swap out air that has infectious aerosols for air that doesn't. And so that's either by opening a window or having a mechanical ventilation system. That's why being outside is so much safer, because you're constantly swapping out the air that you're breathing. You can clean the aerosols, take them out of the air. That's what HEPA filter does. That's a portable air cleaner, and there's a lot of evidence now that they can be pretty effective. Or what the top left is the air cleaning and disinfection. That's using ultraviolet light, and that kills the virus inside the aerosols, right? So that kind of sterilizes it, which is much more expensive to do, but could be a real game changer if they can get it working. We also knew, once we know it's airborne, masks are effective against it, particularly FFP2 masks, and particularly if both people are wearing them. Effectively, you're adding barriers between speech, and they need to be close-fitting, and ideally they'd have a filter that will filter out aerosols. Many European countries mandated FFP2 masks from 2021 onwards. The UK didn't, for reasons that I do not understand. We also knew what transmission wasn't, right? This is the European Centre for Disease Control. They said transmission of SARS-CoV-2 from surfaces plays a very small role, right? The main way you get infected is through respiratory droplets, including aerosols. There was a paper in January 2021 in Nature saying COVID-19 rarely spreads through surfaces. Why are we still deep cleaning? And this is where I feel like we got stuck in March 2020. And even now, you still get exhorted to clean hands, and you still see plastic screens out there. And you still see things branded with UK HSA saying we might have to wash our hands again. I'm like, mate, wash your hands. I'm all for it, but it's not going to stop you getting COVID. And somehow we never really got that. And that's what I find quite interesting. Is like, this is science, right? But this is physics. It's not medicine. And somehow it never got celebrated in the same way, and it didn't break through into the political consciousness or the general population consciousness. And somehow it has not been acted upon. So what about where science wasn't enough? I think data was an issue. Now, this is not an exhaustive list of things that I think went wrong, which could take a long time, but I think certainly at the beginning we were hampered by lack of data about crucial parameters and understanding the science of COVID, which isn't surprising, right? It was a brand new disease, so I don't necessarily think this is the fault, but I'm saying this is something that went wrong. So certainly asymptomatic versus symptomatic spread. And there was some early papers that came out showing that asymptomatic people were less infectious than someone who's symptomatic, which kind of makes sense. If I'm coughing and spluttering, I'm more likely to infect someone because I'm just shooting out more aerosols. But people then thought, oh, well, asymptomatic spread isn't important. But what they weren't taking into account is that spread isn't just a function of your infectiousness, it's a function of how many people you're meeting. And if you're asymptomatic, you're much, much more likely to be out and about meeting people, right? So actually, in terms of the number of people you might infect, it could well be a lot higher than someone who's sick at home. Airborne spread was another thing that took a while to be understood, and I think actually was understood late enough that we'd got too entrenched in the hygiene hypothesis. I think lags in data were a real problem, particularly in the first two waves when things were moving very, very, very fast, and also absent data. So if we're just thinking about this COVID timeline, initially the UK wasn't testing generally, right? So we are relying on hospitalization data and death data, but that's telling you things that happened 2 or 3 weeks ago. And when you've got a disease that's doubling 3 to 4 days, that's far, far too late, right? You should never, ever, ever be basing your current COVID policy on current deaths, because it's just not the right parameter. And I don't think the scientists would ever have suggested that. However, you did see it a lot, particularly in 2020 and 2021, of politicians going out there and saying, well, current deaths are low, there's nothing to worry about. But you can see cases rising already, and you can see it coming down the road, and they're not acting, and then people act surprised. And even now, every single time deaths go up, I get an email from a newspaper saying, well, deaths are going up in COVID, would you like to comment? And I reply, I go, well, cases went up 3 weeks ago, which you also wrote an article on. This is what happened. Like, it's not surprising, and yet somehow people are still surprised by that kind of connection. Long COVID, I wanted just to mention because it's absent. It's not really in any of the SPI modeling as an outcome. And so if you're not going to include it as an outcome, it skews your policy decisions towards preventing hospitalizations and death, but actually there's no incentive to prevent infection. So I think that is one of the issues where it really matters what you're putting into the models. In the first year, there was a lot of confusion on test meanings and understanding the role of age. There was a whole thing in the summer of 2020 about what is a false positive, which I think was way overblown. It really matters understanding the age profile and the age risk of COVID, because what it means is that if you're only looking at hospitalizations and deaths, you can absolutely miss spread in younger populations who are not going to be showing up in your hospital or death statistics. And it also hides the fact that people can then also say, oh, well, it's only the elderly at risk, but actually the risk of COVID is significant at all ages, given other things that will kill you at that age, right? Younger people just die a lot less, thankfully. And then when vaccination came, they started seeing misunderstandings about the role of who was vaccinated and what that meant in terms of death statistics. And then it started off, I think there's some misunderstandings and some purposeful misuse of numbers to try and make it seem as if vaccination kills people, when actually it's a function of who's being vaccinated. So where can science help? It can help with data collection, research design, analysis. It already does that, I think, very, very well. But I think here communication, understanding of science is absolutely crucial to try and explain to people what the data is showing and how it can be used and how it can't be used. Contact tracing is another thing that I wanted to mention. It's a key pandemic control measure. It was successfully used in many East Asian countries. And the essential idea is, instead of using lockdown and isolating everybody, you only isolate people who are most likely to be infected, and that's contacts of someone who's been infected, right? But you have to do it quickly. You have to get to them within 2 or 3 days to stop them becoming infectious, and then you have to get them to stay home, right? The intervention isn't contacting them, the intervention is them staying home. And in the UK, we really placed too much reliance on an app and centralized solutions to this, and we never really gave much support for isolation. Eventually, we put in a £500 payment for 2 weeks, which is less than minimum wage. Most people weren't eligible, and most people who were eligible didn't get it, right? So that was a big issue. And also, at first, we weren't really using the data that we were collecting to understand transmission. And the Royal Stat Society actually published in July 2020 and said, look, you know who's infected, you know who their households are, why aren't we tracking things like household spread and so on? And later we did start using it, and it became absolutely central to understanding new variants, for instance, in attack rates. Poor testing was also an issue. I don't know if you remember the Mensa lab scandal, but in 2021, there was one lab in the Southwest that effectively, for about, I think, 6 weeks, sent back every result as a negative. Now, the overall positivity rate then was about 8%, so I think it should have been spotted much, much quicker, that one lab was sending back 0%. And it came out eventually because people in the Southwest were saying this doesn't make sense, like there are people with symptoms and they're testing negative, what's going on? And when UKHSA finally published its investigation into it, they think actually that lab error might have led to 20 deaths, which doesn't, which perhaps isn't that many compared to how many people died overall, but I think it's totally needless. So where can science help? It can help in designing, rolling out and using things like contact tracing apps and information. It can help with data collection and research design. It can help with automated anomaly detection, which I think is really important, and thinking about what should the key performance indicators be. But, right, and this is the thing, as I said, the intervention is to find people who are contacts of people who have COVID and then get them to stay home. So unless people know they have COVID, or know they might have COVID, prepared to get tested, are willing to provide contacts, are supported to isolate, the whole thing doesn't work. And that isn't science. That's not a science problem. And on that, this is one of the things that I will not understand, right? For almost all of the pandemic, up until last March, these were the 3 symptoms that qualified you for a PCR test, which was high temperature, new cough, or loss of sense of smell. And that was what's on the government website, it was on what the NHS website was. These were the 3 symptoms. But we knew within a year, especially after vaccination, that the symptoms were much more cold-like. A sore throat, headache, muscle ache, a runny nose, sneezing. And we never told people, right? You've got an intervention that depends on people getting tested voluntarily, and we're not telling them what the full symptoms are. Now, the day free testing was withdrawn in March 2022, the symptoms got updated to the full list. The vulnerable, so care homes. So we know that care home residents are elderly, many have other morbidities, they're extremely vulnerable. They're also in a situation where they're going to be exposed to lots of other people. And this is from a paper just looking at excess deaths in care homes in the first wave in England. And you can see there's quite a significant spike, and most of those were directly attributable to COVID, which is the coloured bars at the bottom. And they estimated that up to August 2020, there were almost 30,000 deaths among care home residents, which is 6.5% of all care home beds at the time. And that almost all of that excess was in the quarter of homes that had COVID. So they actually think that even the grey bars there are probably COVID. And it's not just the residents that were vulnerable, right? This is the key thing. It was the staff that were vulnerable. They're a low-paid group of workers. Most of them do not get sick pay. And at that point, there was no payments for isolation. Because they're low-paid and insecure employment, most of them work as agency carers, so they will also work often in 3, 4, 5 different care homes, which obviously adds a big network effect to thinking about what you do. And they also often live in overcrowded homes and often with each other. Now, the modelers at SPIAM later said they didn't know that about care homes. So they modeled them much more as islands than they did as network through staff. But I wouldn't expect mathematical modelers to know how care home staffing works, but someone knew it, right? That was a knowable thing, and they weren't in the room to try and say, you know, you have to change how you're modeling this issue. And so I think one of the key learnings for me is how do we make plans now to ensure that the right people with the right expertise are together to make these kind of things work? Because the consequences, as we can see in the number of deaths, can be really terrible if you don't. We know that key workers were often at high risk from COVID simply because they had other health conditions, and that includes people like taxi drivers, security guards, retail assistants. We know that minority, ethnic, and deprived communities were at high risk through a combination of exposure, they're more exposed, and also because they're more vulnerable to getting really ill from COVID if they got it. So we can see, this is ONS deaths up to July 2022, that the death rate was almost twice as high in the most deprived as compared to the least deprived. We can also see much higher rates of long COVID in that population. So I think here, you know, hard science, it can help identify the problem, it can measure it, but it can't change it, right? So I think what you can then do is say, right, you have to have public health experts in that room, you have to have social scientists in the room, you have to have people who work in the relevant communities and in the relevant fields in the room, and to recognize that science on its own can't solve a pandemic. And I think sometimes there's a desire, particularly I think in high-income countries, to think you can solve it by sciencing it out, right? And you can't. It's important, but it cannot do it on its own. So just on potential interventions, I just want to go back to this timeline. So what are the interventions? You can reduce exposure. That's the first thing you can do. And there are lots of different ways of doing it, right? Specifically, things like infected people stay home, that's contact tracing. And then there are general things that we basically tried out a lot in the first year and a bit, which is lockdowns, limits on gathering, working from home, social distancing, right? Saying just don't mix. Then there's reducing the impact of exposure. So that's things like masks, outdoor interaction, cleaner indoor air. That's saying I want to make it less likely that you get infected if someone with COVID is in front of you. And then they're saying, well, if you are infected, I want to reduce that impact. So that's things like new treatments. And it's access to treatment. It's making sure your hospitals aren't overloaded. And then vaccines, in theory, do all of that, which is why they're the Holy Grail, right? They do all of it. And so if we're looking at these interventions, you've got reducing exposure right at the front and then reducing chance of infection if exposed right at the front. That's by far the most efficient thing you can do, actually, if you want to slow down your pandemic. Then you've got your reducing the impact of infections over at the back end of the timeline, which we spent a lot of time doing in 2020 and 2021. And then in theory, vaccines were meant to do all of it. And if we'd had a perfect vaccine, or if we'd stayed with the alpha variant, that would have worked and you wouldn't need anything else. But what happened was that vaccine or immunity from a previous infection, or both, it does wane. And so really, vaccines are most important, and they have a bit of impact on reducing exposure and reducing chance of infection, but mainly they're reducing the impact of infection and making people a little bit less infectious. And so if we're thinking about this kind of vicious circle, we're thinking, well, how do I interrupt that circle? And these are some of the things I think we didn't do. You know, we never had routine testing of contacts. We had poor communication of symptoms. We had little financial or practical support. We didn't really improve vaccination rates in deprived communities, which have been far lower than in the least deprived throughout. We've made no effort or plan to improve workplace conditions or housing conditions, even though that's been shown from the first Imperial Iraq study onwards as a massive contributor to higher exposure and infection rates. We've not addressed exposure through environmental improvements really at all. Sent out a few carbon dioxide monitors. That doesn't clean the air, it just tells you it's bad, right? We haven't done that much. And those are policy decisions. That's not acting on the science. Like the science is there, the evidence is there, right? And that's partly, I think, because solutions are hard. So now on to kind of interacting with the media bit of it. So I'm just going to start by saying what I've learned from doing these things, but also what I've been trying to do. So starting with TV and radio. So in TV, there are really two things you can do. You can either do a pre-record or you do it live. The advantage of a pre-record is that you can redo answers. The disadvantage is that you can't control the edit. You can't control which bits they use. And often, you could be recording with a journalist for 10, 15 minutes, and they might use 45 seconds. And you don't know which bit they're going to use. And if you do it live, you have no control over what they ask. So often they'll say, will you come on to talk about the latest COVID numbers? And then they'll suddenly throw in a random question about, I don't know, Boris Johnson's COVID parties, or whatever it is. Like, you don't know what it's going to be. But the advantage is they can't edit you. Short of chucking you off air, they actually can't change what you say. It's much more nerve-wracking, but I actually think in some ways more enjoyable. It's more of a challenge. The BBC is the worst because they insist on you having a black screen in front of you if you're doing it remotely, even if you're on a panel like on Newsnight, and so you cannot see anyone, and it's very, very hard to have a conversation with a black screen. I mean, you should try it one day. It's really difficult. So that's always quite nerve-wracking, whereas if you're on something like Sky or Channel 4, you can see the person you're talking to. Radio, I quite like, because I don't have to care about what I look like. So I will never do an early morning TV interview, but I will do early morning radio. And you often have a bit more time. It can often be a bit more conversational. So that's quite good. But either way, you normally have somewhere between 30 seconds and 7 minutes to get across your points. And you have no charts, no visual aids. So you have to prepare, right? There's no shortcut to knowing your stuff. You have to think, okay, what is it that's important about this? What is it that I want to get across? And you go away and you find out the facts. And you think about, okay, well, which of these are important? And you write them down. And you have to try not to be wrong, right? That, to me, is really important. I don't want to be wrong. One thing I learned over time is not too much detail. It's not an academic paper. You don't have to cite all your sources. That's kind of what Professor does for you, is people take your word for it, right? which is fine, but then don't make unsubstantiated claims. You have to be able to back it up if you need to be. And generally think about things like, rounded numbers are just much easier for people to understand and remember than precision. Don't go all precise. And also I think often that gives an unjustified impression of precision of often things that aren't that well measured. Newspapers, I'm just concentrating here on quotes, on stories. So initially, I got asked for comment via Independent Sage or the UCL press office, but then often also via Twitter, direct messages, or email. Like my email's public. Most academics' emails are public. And then once they have your phone number, they'll just phone you or WhatsApp you. The thing here is that you can be taken out of context. So if that worries you, you have to be quite careful. So often, particularly if it's someone I don't know, or it's a newspaper that I know hates me, you send written quotes, right? Which are much harder to misuse, if you like. If it's someone I know and have a relationship with, I'll call them, which can be quicker. You just have a chat about the general issue, and then they'll turn that into a quote. And usually they will check that with you before they publish it. And if you're worried, you can explicitly ask people to send you quotes. Now, like the Americans don't do that. I did an interview for Vanity Fair when China had its really big wave about 6 months ago. And they said, what do you think about America putting in a travel ban? And I was like, well, to be honest, I think it's fucking ridiculous. And then they published that, top headline, scientists said it's fucking ridiculous. And I was like, well, I did think you'd edit it. And they were like, oh, sorry. So that was kind of I was like, oh, okay, fine. So just be careful what you say, because you can be quoted verbatim when you think any reasonable person wouldn't do that. But the thing is, if something's online, they can change things once they're published. And especially if they've made a mistake, or you say, actually, maybe I wasn't clear and this isn't quite right, they can change it. The Science Media Centre is actually really good. If you get on their list, they send around press releases of new studies, new research, or new government policy and ask for comments. Journalists will then read that, and they often pick quotes out of what people have written. So that is a really good way of kind of getting your toes into the media landscape. Do not send essays back. They don't want a peer review of that paper, right? Or if you feel like there are really important things you want to explain, do it, but then have a paragraph summarizing it with some key points. They want a short sentence saying, this looks like a good study, it's important because X, or be careful because Y, right? That's the kind of level people are looking for. Tweets are fair game. Don't forget that, right? And no one has to tell you you've used them. It's out there in the public record. So this is from December 2021, when my sister messaged me and said, oh, the Daily Mail has called you notoriously gloomy. And I was like, what? Oh, yeah. So there I was, like the notoriously gloomy expert, which is me. Hails tentative good news. The Mail actually do this a lot. This is a tweet I did at the beginning of the month when the new variant first came out. And it was a very innocuous tweet, just highlighting this to some people I know who work in Cambridge Genomics. And just saying to everyone else, oh, it's really early days, a lot of mutations, don't really know what's happening. And then I did a Google search on this, preparing for this talk, and Daily Mail have used this tweet and this quote 15 times in the last 3 weeks. And I was like, my God, they're right. They call me doomy, but they're writing about this every day. I was like, so just be careful what you tweet. And in general, I think Twitter can be your friend. I think it can still be your friend, even now it's X. I do a lot of tweet threads where I go through data. And people have they have an appetite for that, right? But they take a really long time. A 15-tweet thread can take me 6 hours, and I'm not joking, right? Because every tweet has to be able to stand on its own as much as possible. You do not be ambiguous. If you are ambiguous, someone will misinterpret you, absolutely guaranteed. Use charts and graphics and screenshots, but the charts need to have all the context they need on them because people can take them without your tweet and reuse them. So if you don't caveat them, they will get used wrongly. I always try to end positively, and I always try to have something at the top, giving people a reason to read this thread. And through Twitter, I've met a lot of collaborators, a lot of journalists, and a lot of MPs, actually. And there's no doubt to me that tweets can have an impact on media and policy. They can change the story. You can get politicians emailing you saying, I want to raise this in Parliament and so on. So you can actually have impact in a way that I don't think you can do in any other way. Like, it's quite a direct way of talking to people. So just kind of the last section on my role as a scientist. So as I said, I wasn't intending to do it. I kind of fell into it by accident. But what I've been trying to do, and I hope now this makes sense given the rest of my talk, is bring in the system perspectives. That's what I try and do if I'm out in the media. So that's things like saying, if you're going to have contact tracing, you need to support testing and isolation. It's not just about the contact. If you want to have a resilient population, you have to tackle health inequalities and consider vulnerabilities. Prevention is always more efficient than treatment, and just trying to kind of bring out that perspective a bit as well. I've also always tried to summarize what I think the current picture is from the data and where it might be going. Often I use SAGE analyses for that as well. And that does include things like if I see things doubling and things looking really catastrophic like they did in December 2020, I will say that. Things look pretty catastrophic. I mean, if I feel the data saying that, that's what I'm going to say. Particularly in the first 18 months, I tried to also emphasize public health messages, which felt a bit weird because I'm not, at least I definitely wasn't then a public health person at all. But I think when there are basic public health messages, that are the messages that are coming out of SAGE, UKHSA, CDC, etc., then I try to emphasize them when the opportunity arose, right? Whether it's distancing, ventilation, vaccination. It's often said public health is politics. And so the question is, when statisticians, mathematicians, or data scientists comment on public health data, do we become public health scientists? To me, that answer has become yes in the pandemic. For many, it's no. But this is an excerpt of a paper that came out last year from John Coggan, talking about is public health just science? And he says, a scientific evidence base for public health is only part of the picture, whether in identifying what population health actually means, determining research priorities, establishing practical and political priorities, or designing and implementing interventions, right? All of those come with a value system underneath. You can't, deciding what is population health at all has a value system underlying it. And he says public health is a justice-oriented field. It is a field with ethics and equity at its heart. And I think that is true, right? Especially a lot of public health is about reducing health inequalities, improving overall population health, improving resilience, addressing poverty and so on, and the social determinants of health, right? That is a justice-oriented field. It has a value system. And when you have a value system, you are innately political. So to me, fairly communicating data also means communicating its implications and putting those implications in the context of current policy, but also what other options are for current policy. And often that would come directly from the SAGE minutes or come from what other countries are doing, right? But to me, that is part of it. It's going that next step and saying, well, this is what this might mean. And if you wanted to prevent it, this is the things you might be able to do to prevent it. This is from Martin McKee, who's president of the British Medical Association, he again from a paper last year. And he says the faculty of public health must decide whether the health of the population is worth fighting for. And then he goes on to say, we are the experts on health and its determinants. We do not hesitate to speak out about biological, and in most cases, social determinants of health, but we are much less willing to address the political ones. And I think, again, this is a really good point. Why are we happy to talk about the biological implications on health and determinants, but not political ones, when actually the outcomes on those populations might be the same? So I guess for me, I was in a position to explain the evidence, what could happen and what could be done to avert some of the worst cases, and I did. So that's, I guess, how I saw my thing. But there are consequences. So I'm just going to go through some of the consequences, and then I'm done. The consequences are hate mail. Now, I think there are many people in this room who will have received hate mail through the pandemic on COVID. Some, maybe even most, from people who thought measures went too far, but also some from people who thought they don't go far enough. So I'm going to show you some. There is swearing. I thought about censoring, and I was like, well, I don't get it censored, so why should you? So here's some. So this says, Christina, what the flying fuck is wrong with you? You could just keep yourself relevant in public, you raging narcissist. People like you truly disgust me. And I really hope you go on to sort yourself out and because you definitely need it. Christina, you are either dismally ignorant or wickedly evil. Do your research, you silly woman. That's a little bit of misogyny tucked in there for good measure. Prepare for Nuremberg too. That's actually quite a common theme. And then sometimes they're just short and sweet, All right, fair enough. And actually, mostly I just delete them. And to be fair, I don't get that many anymore, but during the height, I would get quite a lot. And I delete them by just going to my deleted things and I search for the word fuck and up they all come. So there's hate Twitter as well. COVID nutter, you're disgraceful, you just want to be relevant, loving the limelight, blah, 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 unhinged. And sometimes I do really quite, I think, very non-controversial tweet threads on the data, like this one, which is from March 2022, where I was saying, actually, on the whole, things look fine, but hospitalizations are starting to go up. And this was actually just before the very beginning of the BA2 wave in March 2022, which turned out to be the biggest COVID wave we've ever had today, where 8% of the population got infected at its peak at one time. So again, you get the people are over you, blah, 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 doom and gloom merchant. This is from last week, where I was just saying, the August wave isn't much, it's fine, but I'll probably get something bigger in September. Again, I think reasonably non-controversial, and you still get it. I mean, I don't see it, but you can look for it, you're not in prison, just fuck off, So they're still around. The worst really is the pylons when someone with a lot of followers, like Julia Hartley-Brewer, messages, quote tweets you. So this was in December 2021 when Omicron came, and I was just saying, children are the least protected because they're unvaccinated and the prevalence has been quite low in children. We need to plan for schools going back. And then she kind of wrote this woman is certifiable. And what happens is that you end up with hundreds, and I mean hundreds of people quote tweeting you with abuse. And then it escalates because it just snowballs onto all their followers. And so actually you have to spend several hours just blocking people to try and shut it off. And that can be quite demoralizing. And actually what happened, I wrote the article in December 2021, that actually in January 2022, at its peak, almost 14% of school-age children had COVID. And I think well over 50% got infected that month. So just to summarize, there are many vicious circles in transmission and impact. And the important problem to me is how do you interrupt those vicious cycles? And you have to me, always addressing the key drivers of exposure is more efficient, more sustainable, and because most of it involves tackling determinants of other health issues, it actually has benefits far beyond coronavirus. And it also has basic public health, and it also protects you for the next pandemic, right? To me, that's important. And science is necessary, but it is not sufficient to deal with a pandemic. What worries me is that as the pandemic has continued, opinion has become increasingly polarized, and public health has become really co-opted into the culture war, and I think this is really dangerous, and it has to be addressed before the next pandemic happens or the next crisis, because we're in a situation where potentially anything we do will be undermined by this culture war. And part of the solution is communication of science, both to policymakers and to the public. So I've concentrated on communicating to the public. I think both are really, really crucial. You don't have to do both. They're different things and different skills. But I think thinking about how you're communicating is absolutely crucial. And on that, I will end.
Thank you, Christina. That was excellent. The first comment we have is from Malcolm. He said, sorry, he'd had a bad day when he sent that tweet, and he does apologize. It's a bit like Eurovision here. We've the questions are going up and down on which ones are the most popular. But I thought I'd start with, well, the most popular one, and it's relevant to everybody here, which is, what is the likelihood that the RSS conference is a super spreader? And should we stop face-to-face conferences?
Well, you may have noticed that although I'm not wearing a mask now, I have been wearing a mask in the talks. I'm the only one to do so, partly because I'm going on holiday on Saturday and I don't want to get COVID. Conferences are definitely super spreaders. I mean, they are. Now, I have been keeping an eye on this venue, and I personally suspect that the ventilation here is quite good, as in you can feel air. So as long as it's not recirculating and it's being brought from the outside, I actually think, hopefully, that will reduce the chance. We're in a big room with a big ceiling and we're not full. Again, those kinds of things are good. It's the small rooms, the small breakout rooms that I think are by far the most dangerous, and the chatting over coffee. If you'd known the weather was nice, you might have done it outside. But I do think it is a real issue. I was at a conference in Germany this weekend, and they go into the room, they have a HEPA filter in every room, they opened all the windows, and they gave everyone a lateral flow test to do. So I think there are definitely things we can do to make conferences more safe that we're not doing in the UK.
Maybe this links into the next question, which is, what are the lessons we've learned from the COVID-19 pandemic? And are we better prepared? Which is also a second question. Maybe there's two together.
Well, who's we? Right? I think there are lessons to be learned. Whether the right people have or will learn them is a different matter. I actually think the inquiry is going to do a good job. I think one thing we definitely have learned is how to ramp up surveillance really quickly, how to run parallel trials for vaccines, how to do the logistics of a vaccine rollout. I think we've learned those things. I don't think we've learned some of the other lessons, particularly around system issues and where you have to intervene at a system level. And I worry that we've gone too much into the kind of individualistic type approach, which doesn't really work for public health. So that I don't know.
Okay. Slightly related. If you were in charge of policy for a day, which one intervention would you implement now in 2023?
Clean air inside. I mean, it's like the Royal College of Paediatricians in 2019 released a report urgently calling for cleaner air inside schools because of respiratory infections and because of concentration. And since then, the case has only become stronger. The Royal Academy of Engineers did a massive report saying it could save us trillions of pounds over 50 years. And I don't understand why we're not doing it. We did it for water. I don't understand why we're not doing it for air. So I think I would do that.
Okay, thank you. So this is an interesting question. I'm jumping around a little bit here. The standard of mathematical modeling articles were much lower than normal medical journal standards. Is that appropriate? I mean, you might disagree with the comment, but what are your thoughts on that? Well,
I don't know how you're judging it. I'm not sure that a good mathematical modeling paper looks the same as a good medical paper. So I don't know what basis that judgment is on. I think actually a lot of the mathematical modeling papers were really good, and I think the issues with the models tended to be in some of the assumptions around how people mixed and how the networks worked and what some of the parameters are and what outcomes they modeled. So I don't know. I don't think I do agree that they were bad. I don't think they were mainly.
Okay, thank you.
I do think just one more thing though. You do see papers where people are modeling the pandemic a year or 18 months or 2 years out. I think that's nuts. Because policy changes, right? Policy changes or a new variant or something fundamental happens that makes your model null and void. I just cannot understand what the utility is of trying to say where we're going to be in a year or a year and a half. I don't think we know.
This is one that's, I guess, close to people's hearts. Lots of people became armchair statisticians during the pandemic. How do we encourage enthusiasm while explaining that it's more complicated? I suppose that the same could apply to armchair experts on Ukraine and cement used in schools and a whole range of things. So how do you deal with, how do you keep the enthusiasm going, but at the same time explain that it's more complicated?
You know what, I thought about this a lot, and I'm not even sure you necessarily want to keep the enthusiasm going, because I think we've lost our respect for expertise. And that worries me, right? Okay, like take something like the lab leak theory, right? Opinions on that have to be based on a really, really good academic understanding of how viruses work and evolve. And I do not have the biology or the virology to know that. I can't assess the papers, I can't assess the evidence, I don't have an independent opinion on it. My opinion comes from the scientific consensus of that body, that field, and experts in that field that I have learned to trust for other reasons. And their consensus is it's not a lab leak. So that's my position. And equally, I think there are all kinds of things, whether it's concrete or Ukraine or stats, where we have to understand that we're not experts, and looking at a couple of YouTube videos does not make you an expert. And I get it from mostly men in my close circle of friends and family who are very intelligent men. Most of them are computer programmers, which I find very interesting. And they think they know better. And it boggles me, because they know they're clever and they feel like they can just take it out and they want a bit of code, and suddenly everyone else is wrong. And I don't know where that arrogance has come from, but I don't know how to fix it either. And Elon Musk is one of the worst people at it as well.
And maybe the final question then, what was and this was actually one of the first questions that came through, what was the motivation for creating Independent Sage?
Well, I think the very original motivation was that at that time, the government was saying in March and April, we're following the science, but there was no one knew what the science was, and no one knew who was on stage, and there was no public minutes or anything. And I think we forget that now because it was all made public. And so that was the original motivation. It was, okay, well, let's try and have some of these conversations about what policy options there are out in the open. Now, I remember when they got in touch with me, I was like, that's a bit odd. And I said yes, and I literally thought it would be one public briefing that no one would watch, and that was it. Like, that's what I thought I signed up for. That's not what happened, because it turned out there was actually a really big appetite for having those kind of conversations in public. And I'm not saying it's causally related, but the membership of SAGE became public the day we had our first public briefing. But that was the original motivation. And then in June, the government stopped its daily press briefings and kind of said, we're going to go ad hoc. And then we felt there was space to try and keep explaining what was happening. So that's kind of why we carried on.
Great. Well, once again, thank you very much for the presentation today. I know you've come. I know you're traveling a lot at the moment, and still doing lots of super spreading while you're doing that. But it's been a pleasure to have you here. And could we just give a final round of applause, please, to Christina?